Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Yesterday, a patient had come by through my office and he handed me this book called Crooked by Catherine Jacobson Ramin. Um, and he suggested that the way that I approach my practice is very similar to what this book's message is, which I found very insightful. So I said, of course, yeah, thank you. I love to read it. I appreciate it. Um, and he's like, yeah, mainly I wanted it to be out there for your patients for them to see. But I think it's important, if you do have opportunity to read it, to look through it. So I cracked it open yesterday. I had a few minutes in between patients and stuff and just flipping through it. And something interesting, within the first 10, 15 pages, I was kind of blown away by some of the statistics that uh, she brings up in the book, um, and the philosophy of it all, and how the spine care, the back care world is so broken, and as the book suggests, crooked. Um, right in the introduction, she says, "Successful rehabilitation is never passive. It requires sweat, persistence, and a lifetime of hard work. Although it won't be easy, or quick, or painless, by the time you finish this book, you'll know how to avoid therapeutic dead ends." And in the totalitarian of patient care, shouldn't that be the most important thing of how we're going to prevent our patients from hitting these therapeutic dead ends? She goes to talk in the first chapter about how like patients will choose to go to a primary care doctor and choose to go to a uh, chiropractor, and despite the limited evidence on some of those things of why aren't they getting better, and how low back pain patients quite often don't go back to work, and the concept of what happened with workers comp and how workers comp came about, all this kind of packed in very short readable sections in the first chapter. The interesting thing that caught my mind, when she was going through her own journey of her back pain, she went to a primary care doctor, sent her to a spine surgeon, big ortho spine center, and at the end of the day, the first day, she went and thought she was going to see the physician, the spine surgeon, but it's like, you know what? You're going to see the PA, NP, whatever. They ordered x-rays and she was kind of sent on her way. On her next visit, she came back. She's like, okay, this time I'm going to go everything with the surgeon. We'll be able to make a plan. But ultimately, what ended up happening is she got hooked up with a physiatrist, um, which she says pretty humorously, but I think it's kind of true in certain senses. I didn't think it's true across the board and blanketed how she states it, but I think it is important to know this. And plus one for the team physiatry out there. Um, Physiatrists are often confused with podiatrists and psychiatrists, but they are MDs or DOs who specialize in physical medicine and rehabilitation. Those who work independently are worth their weight in gold because they're experts, anatomical sleuths, and skilled in exercise physiology. All which is true. Some of the best diagnosticians that I know have been through physical medicine rehabilitation. Um, anyway, those that work for spine surgeons typically make a living performing spinal injections and other interventional pain management procedures, bolstering the surgeon's bottom line. And that in itself is not untrue. Um, During my interview process, when I was trying to figure out what I want to do post fellowship, that's essentially how at least one of the practice I interviewed at made me feel is, we just need to do injections to help cover our overhead, to help make sure these patients aren't going somewhere else to get uh, care. And, they try to make it sound like it's a lucrative thing. But what made me feel so discouraged about that practice was, what are we actually doing for the patients at the end of the day? She continues on this book and how spine surgery is not always the best answer for a lot of patients. Um, and it's quite funny that even just today, I had a patient who I was talking to, and this concept came up where I asked the patient where they went to physical therapy, and they named a place in the Central Ohio region. I said, unfortunately, they're no good. Um, and I explained, like, just think they're almost incentivized to not make you feel better. So their surgeons can do a surgery that will reimburse and pay better. Of course, I would like to think that that's not always the case, but um, and more people are out there doing good than not good, but there's no empirical evidence that that's actually true. So it was an interesting conversation I had with, back-to-back days with patients, and some of the disheartenment that we have in the back pain world. Um, I think, this kind of more on my own tangent, that people that are diagnosed with back sprains and strains are the most common cause of back injuries. What we're diagnosing this based off of symptoms, back spasms off of symptoms, and not actually diagnosis. Um, we can't just say, oh yeah, this is exactly what's going on by basing it off of a patient's once they come into a physician's office. There needs to be a thorough physical examination, and that might not even get to it because honestly, we can't see the discs. And I say this because anytime that you interrupt a disc, you can see the reaction that patients get and how much pain they're in. And this is the concept of the discography, of where we inject medication to try to pressurize a disc to see if that disc is causing patients pain. Um, there are a handful of physicians out there that have decided to do therapeutic injections into the disc and use a little bit of dexamethasone or other steroids combined with a high percentage of lidocaine or other anesthetic agent that can help alleviate the pain. So we know some of this is actually coming from the disc, and the symptoms are so similar. Oh, my back is spasming. Oh, it's tight. Oh, it feels like something just jumped up and grabbed me and bit me. So these are all very similar to what patients come in with, these back strains and back spasm injuries. Um, a I guess my argument would be in this is, why do back spasms happen so often, but other muscle spasms don't? Is it because our backs are weaker? Well, that doesn't make sense. I mean, we use our backs all the time. We're standing, we're walking, we're running, we're twisting, we're doing all those things. We're using those muscles often. Does anyone say, "Oh, I'm suffering from a bicep spasm, bicep strain," without actually straining? Like, I'm a bigger believer that the root of the problem is a lot deeper than what people say it is. And yeah, most back pain does go away, but that doesn't mean the problem is fixed. And I think that's something that we need to start talking about. And hopefully, I think that's what this book is going towards. And I'm looking forward to diving deeper into it. Again, I just read the first chapter, first few pages. Um, I think there's a lot to it, and I think it's a lot more complex than anyone wants to make it be. And the unfortunate part, and as she says in the book, is, I don't think people are willing always to do the work. And that can cause a lot of disheartenment from the provider side, from the practice side, and patients start distrusting the providers, and it can cause a lot more turmoil and a lot more distrust in the medical society when we have places that are charging for their x-rays and charging for their MRIs and doing epidurals just to get this patient all the way to a spine surgery or another orthopedic surgery so they can pay the big bucks. I don't want to sit here and try to act like I know everything, and I definitely don't want to say surgery is not indicated for a lot of patients, because it certainly is. And I think that's probably the most important thing, is what is the best thing for the patient at the right time. And sometimes that might involve a surgery, and I'm totally with that. But I think we have such a poor understanding and mindset and mind's eye of what back pain is, or any musculoskeletal disorder. Um, I can, recall times that I was back in my training, and a patient would present with a certain condition. Um, and actually, I'll just give this example because I thought this was fascinating. We were doing rounds for inpatient consults during residency, and I had a patient that I went to go consult on, and the patient had left arm weakness. So the immediate workup from the ED was, okay, this has to be a stroke, brain, uh, CTs, MRIs, neuro checks, observation, the whole 9 yards, right? So interestingly, I had seen a patient like this before, and I went to go see them, and I just was talking them through a basic conversation, history of presenting illness, and um, what they were doing the night previously. And the patient was just like, you know what, I was playing cards with my friends, and I was like, okay, what were you doing? And oh yeah, you were drinking some, and just staying up late. It's like, okay, were you leaning your arm up against anything? It's like, yeah, I had my arm up just like that. And um, for those of you that use buzzwords is in studying, or those of you that aren't in the healthcare industry, it's, this is it was a classic Saturday night palsy, the radial nerve getting compressed and causing wrist drop. And they just did a multi-million-dollar workup for this patient, probably close to pushing medications that they shouldn't have, just for something that could have been easily diagnosed on a thorough physical exam and history. And I'm not blaming the emergency room. I'm not blaming the medical doctors that treated them or anything. But when my attending saw it with me, he was kind of like, why are they putting this patient in the hospital when this could have been easily taken care of in another place? And then that was like one of the days that I realized how important the physical exam in a history is. Um, and the other problem with most of the physical exam and history of low back pain is this, it's never just one structure. Well, more often than not, it's not just one structure that's causing pain and discomfort and all those things. It could be the disc, it could be the ligaments, it could be the muscles, it could be the facet joints, it could be whole other things that we might not even know about yet. The vertebral body, as we know, there's vertebrogenic pain and discogenic pain, uh, different types of nerve pain. So we don't really know, and I think that's why it's hard to say like, oh, just go rest, it'll be easy. And in fact, back in this book, talks about how rest and relative rest is actually not really the best option. Um, you get to rest at tolerance, right? You can't not expect to go pick up things, but if you're resting your body in those situations, then it can cause a lot more problems in the long run. And it's one of those, the perpetual rest at the beginning causes more back degeneration and resting, and that causes more, and it ends up being a cycle. So it's not uncommon for people that are out of work for 2 years to kind of never go back to work from disability. Um, I have a pretty uh, decent understanding of that, but I don't know it to the extent that I should probably. And often I tell my patients, like, I prefer not taking you off work unless you have a labor intensive job. Like, we need your body moving a little bit, because if you're going to be stiff and rigid, it's just going to form bad neural patterns and neuromuscular patterns, and this might cause more problems in the long run. So I really encourage them to like try to look at other things to try to help with their pain. And there's some controversy about ice and injections and steroid injections and non-steroidal and anti-inflammatory medications, which is a completely different tangent that I have on a different day. But mainly, I just want to spend a little bit of time talking about this book and what I've found in the first few chapters, and I'm looking forward to dive in deeper to it. So anyways, thanks. Thank you, everyone. I hope you guys are having a good summer. If you have any questions, feel free to drop me a question, a comment, send me a message on social media, and we'll talk to you soon. Thanks. Bye.